Mic testing. Can anyone hear me? Hello?
Yes, welcome, I can hear you. Don't need to know anything about that.
A warm welcome on this Wednesday evening. I'm Meena Mistry from Shivdev, and I'm thankful and delighted to see all delegates that have joined us tonight. We are grateful to have Dr. Rama with us, who will enlighten us on managing neck pain. Listen carefully as we'll be posing 2 questions during the question answer session. And 2 lucky participants who correctly answer the questions will have a free book gift couriered to them. This webinar is also being live streamed on Shivdev Training Academy's YouTube page. You're welcome to share the link that is on the chat. We have a special guest speaker, Raki Dullip, a senior associate from ENS Africa, South Africa's largest law firm, who will answer questions on our Poppy Act workshop at the end. So sit back, relax, and enjoy the webinar. I hand off to Dr. Rama. Thank you.
Am I good with sound? And good evening, and thank you so much for allowing me to do this presentation. And today I'm going to be discussing the patient in acute neck pain, its clinical presentation, pathology, and treatment. Without detailing all the gross anatomy, let's discuss the structures in the cervical spine that may cause neck pain. I will also explain tests used to screen for these possibilities and the investigations required to confirm the diagnosis. So the pain-sensitive structures in the cervical spine are the facet joint, the nerve root, the cervical disc, ligaments, muscles, and tendons, which makes up the soft tissue, the vascular components, the meninges, and the space-occupying lesion, which could be benign cysts and Arnold-Chiari malformation. In this slide, we see the 3-joint complex, which is made up of the vertebra above and below, bilaterally at the facet joint and the disc in between them. If any of the facet joints or the intervertebral disc are in a state of compromise, then that segment is known as spinal dysfunction. These facets have a capsule which monitors its integrity and position within the facet joint in the spinal column. In the image, we see a diseased facet joint with narrowing, osteophytes, and degeneration of the cartilage. The facet joint has a rich nerve supply, and it's innervated by the medial branch of the dorsal ramus. And it has a rich supply of mechanoreceptors and nociceptors, which we'll discuss in a bit too. So every time you feel a bit of a niggle coming on in that neck where you feel you need to stretch or mobilize it, there's probably some irritation taking place within that nociceptor, and that sense of that feedback all the way up into that spinal cord, indicating that some discomfort is felt by the patient or even yourself. We will now discuss the testing of the facet joint at the cervical spine. Now, in this slide, we see two fairly provocative and sensitive tests for facet joint pathology. They can be uncomfortable for the patient in pain, and prior warning is advised. To the left, we see a maximum cervical compression test, and as the name suggests, it is an axial loading force to compress the facet joint. Another way of actually performing the test on the left is by taking your hand, placing it on top of the patient's head, and you give it a bit of a thump, and the patient would react the same, and you'll be able to get a nice conclusive diagnosis there. The image to the right shows a test whereby the cervical spine is taken through extension, lateral flexion, and rotation. And we do this from the second cervical facet right up until the C7. So from C2 to C7, we perform this test. It's called the Chems Test. Now, a thumb pressure or web of index or the thumb is used. And a positive test is usually indicative of localized pain at the facet. That is exactly where the pressure is applied. Now here you've got to monitor for any referral or radiculopathy. This will then indicate any nerve root compression. The same tests can be used along with others to determine the exact disc level that could be implicated. So with this test, always make sure that you are pressing directly on that entire facet joint. The cervical nerve root is the next painful structure that can cause quite a bit of mayhem. It's often a tricky condition to treat for most, and usually fails to conservative care, analgesics, and causes a decrease in quality of life, and often can end up in surgery. But a thorough clinical examination does assist in making the diagnosis sooner, and management can prevent any worsening. In the image to the left, we see a beautiful dissection of the life force, and we can appreciate how integral it is to have an optimal functioning nervous system. In the image to the right side, we see the mixed nerve root exiting and the ventral ramus innervating the motor component of the limb and the sensory component ascending the dorsal ramus of the spinal cord. Now, this mechanism is the baseline of pain and its perception to any stimuli. In the next slide is the beautiful brachial plexus, which I absolutely adore, and a neurological marvel it is. And each one of these nerves is affected by the cervical spine's integrity and motion. Now, for nerve root tests of the upper limb, each patient presenting with neck pain and radiculopathy has to undergo these tests bilaterally. Use sensory tests, use your reflex hammers, your pinwheels, do the myotone strengths, and see exactly where there is weakness. So this will allow us to actually detect which nerve root would be involved and the severity thereof too. With all the tests in the image, we are assessing for weakness. The practitioner should use the same side to test the patient on both sides to improve accuracy. These can be done at the follow-up visits to assess if there's any regression or any progress with regards to the patient's pain. This exam can be done in 60 seconds, and the more you do it, the easier it becomes. If the patient is in severe neck pain, you can always ask them to push or resist to 50% of their power, and you can do that bilaterally. The next possible cause for neck pain is the cervical disc, a vulnerable structure and a cause for neck mayhem, altered gait, paralysis, and death. Assessing gait is absolutely crucial in these conditions, along with lower limb strength and reflexes. In severe cases of central cord stenosis, patients often feel a disconnection and floppiness or silliness in the limbs is what they usually will describe. The outer disc is innervated by the sinovertebral nerve, and an outer tear can cause neck pain and not necessarily any radiculopathy. So these are often brought on with heavy loading at the gym and sometimes with trauma too. In the slide, we can see at the bottom with the 4 stages of a disc herniation. I'll skip straight through to the 4th piece there, which is a complete sequestration, meaning that the disc content or the nucleus pulposus has pushed right through its contents, right around the annulus fibrosus. And that disc is happily sitting on the spinal cord and on the nerve root. Now, to test for any cervical disc prolapse, this can be done for any nerve root encroachment as well. And there are many ways to do this test. The above method shown is to place the patient in a seated position, and you ask them to strain as though they're sitting on the toilet seat. You know, there are better ways of doing this. I usually ask my patients to take their thumb and put it in their mouth and blow onto the thumb, and it increases the pressure, and the patients usually experience quite a bit of pain localized in the neck. Another thing I usually ask my patients to do is to cough in their hand, and that usually induces the same type of response. But most times upon history, the patient will usually say, when I'm coughing or when I'm sneezing or when I'm brushing teeth at the back and with the gag reflex, they usually find worsening neck pain. And these type of symptoms or this type of test can easily be used for any lower back pathology, which we'll discuss at another time. Another pain-generating structure is the soft tissue. These injuries are way too common. In South Africa, we see high-velocity motor vehicle accidents. We see rugby and football injuries, and physical abuse and domestic violence too is a frequent presentation to the casualty departments. Now, whiplash-associated disease is a topic on its own, especially when it's accompanied with concussion. However, from the images above, we see the multitude of pathologies and possibilities that could go wrong with this entire neck in the case of trauma with regards to soft tissue. Here too, a good case history taking is exceptionally important. And as long as we fully understand the trauma, it does tend to make the management of these patients much easier. If there's a loss of consciousness, we need to establish who was there to witness the entire incident. How long were they out for? Was there a coach? Was there ice supply? Did the patient come away in a stretcher, etc.? In the case of a motor vehicle accident, you want to know, did the airbags deploy? That's if the car had any airbags. Where was the patient's position in the vehicle when the accident had taken place, etc. To test the range of motion and assessing soft tissue pathology, a thorough case history, as I discussed, is of vital importance. Assessing the range of motion can also help with determining instability and if it is ligament or muscle. Now, asking the patient to move the neck allows the muscle, the ligament, and the joint to be tested. But passive testing by the examiner eliminates muscular control, and any pain felt can be successfully diagnosed as a ligament sprain and instability. Now, in these trauma cases and persistent neck pain, Radiology is recommended, and I usually do stress fuse along with the other x-rays of the AP, lateral, and obliques. But if you are in doubt and if you find the patient's pain is worsening, then go ahead and request a CT scan. That will still be gold standard to view any underlying fractures that will be completely missed on x-ray. Yet another cause for neck pain is vascular pathology. Now, two main arteries are the carotid and the vertebral arteries. Look out for headaches, visual disturbances, dizziness, and blackouts. Of course, the vertebral artery, in the case of the spinal column or the cervical spine, we know that the root coming off subclavian artery goes through C6, exits C2 at the cervical spine. So we're always very cautious when it comes to the vertebral artery. Vascular tests for the cervical spine. Now, a good cerebellar exam is always a good place to start when it comes to any of these signs that the patients present with. In high-risk cases where cervical manipulation is performed by a chiropractor, the screening is always done with a Wallenberg's test. Now, all manipulation to the cervical spine is done in a supine position with the neck in flexion and minimal rotation is induced. This protects the vertebral artery. And in cases where red flags occur with patients, we'll never do any spinal manipulation there. Now, vascular testing of the cervical spine here, always palpate. Make sure you're getting hold of the pulses and the carotid on both sides. If you're uncertain, go ahead and also auscultate that entire artery. Do blood pressure on both arms. Perform a Wallenberg's exam or test. And if you really are in doubt, go ahead and request a Doppler ultrasound scan on these patients. Now, this is the Wallenberg's test. Here, the patient's head is taken off the bed, as you can see, into extension. We laterally flex the patient's neck, and then we take them all the way into rotation. Now, this is a very provocative test, once again, so the patient can experience symptoms, and they can experience some of the symptoms in the room. So you've got to explain to them exactly what they may feel and what you're going to do to correct it in the room. So here you're looking for any nausea, any nystagmus, which is exceptionally common, any diplopia, and you want to monitor the patient's speech. So you speak to them, ask them how they're feeling in this position here. This should be repeated on both sides. Space-occupying lesions in the cervical spine. This can always be done with your routine lymphadenopathy. Now, when you palpate in the neck, make sure you feel all the triangles. In these cases, where the patients usually complain about neck pain and they're having difficulty swallowing or pain with swallowing, you want to go ahead and do the thyroid examination. Ask them to swallow. Make sure those lobes of the thyroid are actually ascending with the swallowing test. Valsalva test, as we discussed in the previous slide, can be used to rule out any pathology here. Here, always send the patient for ultrasound if you're coming across a mass or a lesion that's just not feeling like a isolated lymph node. And of course, on history, you'll find out if the patient had a respiratory tract infection in the past 2-3 weeks. If you're really in doubt and the ultrasound scan does reveal some pathology, you can send them off for the MRI. And of course, you want to go ahead and do a blood workup on these patients too. Now, infections do cause neck pain, especially meningitis, which is something that we are always looking out for in patients with headache and stiff necks. And the history is, of course, of utmost importance: fever and night sweats, nausea, vomiting. And then we've got the two beautiful tests, the Brudzinski and the Koenig sign. In case you guys have forgotten, the Brudzinski sign at the bottom is where the patient's neck is flexed. You flex the patient's neck, and immediately you'll see that the patient starts to flex their legs at the knee to take the pressure off that entire meninges. So it makes it much more easier for them to bear this entire test. The Koenig sign is exactly like the straight leg raise that we do for nerve root encroachment in the lumbar spine. Patients completely supine. You're going to take the leg and flex it, and the patient is going to go ahead and resist that entire flexion at the hip. That's also a positive sign for irritation of the meninges. Of course, you want to go ahead and request bloods and a lumbar puncture in these patients if you're querying the pain and stiffness from the neck of an infectious background. Of course, the patient on the top there, apart from the insulation tape on the eyes, that's a typical SCM or congenital type of spasmodic torticollis that you'll see, or a wry neck. You can see that SCM muscle, how taut it is. But we'll discuss that too. So our patient presentation goes like this here. We got a 26-year-old female who presented to the practice with neck pain upon waking up. A very frequent presentation, I'm sure. 4 days duration, extreme neck and shoulder pain. Patient uses the PC on a daily basis, and she's a sales rep. She has been to a GP, administered an intramuscular injection, prescribed oral NSAIDs and muscle relaxants. Patient had a relief for the night, but the pain returned the next day, and the use of the meds was unsuccessful. The patient is a smoker. She smokes 6 cigarettes per day. Previous history of neck and shoulder pain. Infrequent headaches since a teen. Aggravating factors are cervical spine movement, sneezing, sleeping on either side, driving for long periods of time. She starts getting this neck pain. Her relieving factors are heat packs, heat pads, Transac patches, muscle relaxants. It does allow the patient to sleep, but the range of motion and the pain when turning over starts becoming restricted. She denies any history of trauma, but does recall a motor vehicle accident 8 years ago, but she can't recall any fracture and no injuries thereafter. She does admit to being stressed. She says nothing remarkable. And there's been no other trauma to this patient. An occasional dull ache at the left-hand side, brachium is what she does experience. And the patient is not doing any exercise now since COVID-19. So she's staying away from all the gyms. Physical examination, she had normal vitals. The neurological examination was normal. She was just tended to palpation at the cervical facets, the spinous process, the levator scapula, and the trapezius muscles. She had upon resisted shoulder abduction, she was slightly weaker on the left-hand side, and she had pain upon doing that test. Her glenohumeral joint, the shoulders, the range of motion there was absolutely perfect bilaterally. Orthopedic examination revealed a positive Valsalva. She and the rest of the cervical orthopedic tests were not performed, as she was quite uncomfortable at the practice. A cervical spine, the range of motion was restricted in left side rotation, right side lateral flexion, forward flexion, and extension, where she could only move her neck fairly okay to the right side in rotation. Now, what do we actually consider in this type of case? Do you send the patient off for x-rays immediately? Do you put the patient in a collar, a cervical collar that is? Physiotherapy, more anti-inflammatories or analgesics? Refer the patient to the neuro? You want to consider an MRI of the cervical spine in this case? So let's see. In a cervical spine x-ray, we will only request it, well, from my side, that is, if we're finding that there is significant neurological fallout. If we find that there's been trauma, if this patient's completely tended to palpation, where we're querying something where there was a lesion at the spinous process, of course, querying a fracture, any congenital anomaly which will pick up on the physical appearance that you may want to go ahead and just rule out. Any radiculopathy and paresthesia in the upper limbs. I would usually request an AP and a lateral if the patient is non-responsive after the first 2 treatments of treating this particular patient. I will then go ahead and do an oblique as well on the very first time for requesting x-rays if the patient had a distinct radiculopathy. Now, when we get these x-rays, we have to ask, what are we actually looking for? We get these x-rays, we put it up in the box, but what are we actually looking for? A loss of lordosis or a reversal of the lordosis is something that we are seeing more and more often. Disc narrowing, spondylosis, the alignment of the vertebra, the obliques when you're requesting, the IVF when you're requesting these obliques. Take a look at any narrowing of that C1, C2, any instability coming on there. Retropharyngeal space can often detect some pathology. Now, you may have seen numerous radiology reports stating that there's a loss of cervical lordosis, most likely due to muscle spasm. But what does it actually mean? What are we doing with those patients when we're seeing that the cervical spine curve has become completely lost? Is the straightening or reversal of the lordosis normal? Most practitioners tend to overlook this treatable condition in neck pain patients. Under the circumstances of trauma, it can be perfectly normal, but must be treated accordingly to restore to a normal cervical lordosis. Of course, back then, about 20 years ago, or even 15 years ago, we all used to see cervical spine x-rays, and on the lateral, unless there was any trauma where the curve was completely lost or gone into a reversal, where you start seeing this massive loss of the curve and a lot of muscle spasm. Now we're seeing it a bit more often. And with the previous talk that I had done with regards to the use of technology on neck pain and neck pathology, we are going to be seeing this more often because a lot of the kiddies are using the cell phone, using the tablets, using the PCs. So the entire structure and the functionality of the neck is starting to change. And we're seeing more rounding of the shoulders, and the neck is coming more and more forward. So this type of pathology, I can assure you, you're going to be experiencing it in practice from Monday morning, even more after this presentation. Now, is there a correlation between the cervical spine X-ray and neck pain? Now, in 2013, there was a brilliant study done at the American College of Rheumatology, and they did a study where they re-evaluated patients that they had seen on the cervical X-ray lateral. And these patients all had fibromyalgia. Fibromyalgia patients are very, very prone to having significant neck pain. And the study where they actually measured these X-rays with the Cobb's method, 138 of the cervical spine X-rays were done, and an additional 23 patients were used with the cervical spine X-rays, were visually analyzed and were not measured. And the result of the study, from the 138, 71% had a straight spine, 17% had a slight lordosis, and 12% had a normal cervical spine curve. The additional visual inspection group, where they were not measured, 20 out of the 23, that's 87%, had a straight neck. And the other 3 had a slight cervical spine lordosis, but none of them, by visual inspection, had a normal curve. Another study in 2005 revealed that patients with a lordosis of 20 degrees or less were more likely to have cervicogenic symptoms. Now, the posterior tangent method was used in the study, and from C2 to C7 on 277 of these lateral cervical spine X-rays. And the association between the cervical spine and a lordosis of 0 degrees or less was significant. So the odds that a patient with cervical pain had a lordosis of 0 degrees or less was 18 times greater than for a patient without any neck pain. The next slide shows the posterior tangent method and how we have a line from the back of C2 going all the way down, and from the C7 going all the way up with the posterior vertebral body, and that angle is measured. So a straight cervical spine is 0 to 16 degrees, and any reversal of that cervical spine is less than 0 degrees. Of course, a normal cervical spine X-ray using this method is between 36 and 45. So these are complete curves in the wrong places that we start to see. Now here in the center, we see an abnormal curve where that cervical spine lordosis has been completely lost. We can even call it a bit of a kyphosis taking place there. And in the image to the right side, we're seeing a completely straight spine. The cervical collar, what are the indications for them? Who do we immobilize? So any patients with a history of trauma, if the patient is unconscious, complaining of neck pain or tenderness, limitation of movement, usually patients find their head difficult to actually take off the pillow, any neurological deficit, significant head or facial injuries after the incident of trauma, and of course with a mechanism that may indicate any spinal injuries, where it's a pedestrian or a cyclist, more than 30 kilometers per hour, a passenger in an MVA, more than 60 kilometers per hour, a fall from a height of 3 meters or more, kicked by or fallen from a horse, or thrown out from a vehicle. The problem with the cervical collar is that any active treatment and neck mobilization with daily exercises of the cervical spine has better outcomes. Initial immobilization after whiplash is associated with prolonged symptoms, and more rapid improvement can be achieved through increased activity. Now, the use of soft collars, we can limit them to 10 days, and the duration of 6 weeks hasn't been proven to be effective in these patients. The other concern is, of course, any atrophy of these muscles around the cervical spine, which makes it even more challenging for these patients to get back to the A game, get back to sitting in front of the PC or even driving for long periods of time, because their neck really starts becoming a bit weaker. All the research whereby rest and collar were compared to any mobility intervention in whiplash injuries or neck pain, the groups where immobility was the protocol had shown no relief in pain nor range of motion. Therefore, early mobilization does result in better outcomes regarding pain and cervical range of motion. Now, how does chiropractic help this case? By understanding the case that I presented earlier, there is a neural component, as the patient has a degree of weakness in the shoulder abduction and she is in pain. There is definitely a muscular component, as the patient cannot rotate the neck to the left side. And there is a facet joint component too, as the patient's Chems Test, or that facet palpation test, is quite tender for the patient. So what we would do is adjust or perform spinal manipulation therapy. It's fundamental that we go ahead and increase range of motion at that restricted cervical segment. And this is performed through spinal manipulation therapy. Now, the majority of cervical spine restrictions in this particular case, with the setting that I've given, with the patient having a difficulty of rotating the neck to the left side, we can often implicate C3 and C4 as a culprit. And the reason being is because a few muscles attach to that entire area, and a few muscles have a nerve supply from this particular segment. And that's what we're going to take a look at now. Once again, the positioning of that chiropractor adjusting the neck, you can see the neck is well flexed, as we discussed, just to protect that vertebral artery. Why do we even adjust that spinal segment? What's the purpose of it? What does it do? Now, the facet joint creates a gapping. This then reduces the pressure and therefore less pain. Now, that anti-nociceptive effect is also achieved, which normalizes pain and perception via the neural pathway. And that's what we were talking about earlier when I was detailing the facet capsule as a source for neck pain. So any interruption in that entire area starts sending off this nociceptive feedback, and the adjustment corrects it because we are sending that exact feedback and eliminating that the nociception. Soft tissue modalities is something that we would also do in this particular patient. Now, in this image to the left, we see that dry needling is being done. And in this particular case, this was done over the levator scapular muscle on the left-hand side, as this muscle's main function is to allow for left-hand side rotation, whereas trapezius on the left-hand side allows for rotation to the right side. Thereby, understanding the anatomy in the previous slides, as we have discussed, allows for a much more efficient management plan too. Now, the image to the right shows an electromodality. We usually use this to relax the muscle a bit more and to enhance the entire spinal adjustment and the dry needling protocol. The next slide takes us into the myofacial trigger points. Now, these are well-documented, published literature, and there's brilliant books about how these muscles and these myofacial trigger points can refer pain elsewhere. And of course, localizing and knowing the anatomy and also knowing where the trigger points lie in these muscles is it tends to help quite a bit as to where you're going to go ahead and dry needle these patients and how you're going to go ahead and treat them going forwards, and also where the source of the pain may come from. And this also applies to the lower limb, buttock muscles, patients having hamstring injuries, pinched nerves in the lumbar spine. But basically in the top image where we're looking at the trapezius, we see the two trigger points marked with these two tiny blue X's. Those are the trigger points that we're starting to see in this entire trapezius muscle. And if you look just below it where it says referred pain patterns, we are looking at how that referral pain can go into the side of the jaw, over the parietal area of the scalp, over the occipital area of the scalp. Similarly with the levator scapular muscle, which is the image at the bottom. And here what we're looking at is that levator scapular muscle attaches to the superior medial border of the scapula and attaches all the way upwards towards that cervical spine at C2, C3, C4. On the right, we see the two trigger points of that levator scap marked by the two white X's. And we can see that dull referral pain going down into the brachium, very similar to what this patient had experienced. Why do we do the dry needling? What's the purpose of the dry needling? Now, myofacial pain trigger points, we do know that those areas have acetylcholine, which are released from the motor end plates of that muscle. This increase in acetylcholine results in a shortening and a contraction or a tightness and a restriction of that entire muscle. And this now leads to a reduction of oxygen supply to that particular muscle. This causes irritation. As soon as you press on that muscle, you'll start finding that the referral pain starts to travel elsewhere. Now, a trigger point is very different from a tender point. A tender point is a tender point which you're going to go for, and someone presses on a particular area of your spine, and it will be tender. But a trigger point is that part of the muscle that tends to refer elsewhere. And each one of these muscles have a set demarcation of how they move and where they move to. This now causes an increase in prostaglandins, bradykinin, cytokines, and you get a histamine release. This now sensitizes the entire sensory afferent nerve fibers to that muscle. So what we do is take the dry needle, get into the trigger point and insert it there. We also have to understand that this is not acupuncture at all. Acupuncture has its own rationale. It has its own science, which I'm completely unfamiliar about. I'm not too sure about the Qis and energy lines of the body, but that would be acupuncture. Dry needling is getting into the muscle where it's tender and causing a referral pain and activating the trigger point to allow an influx of blood flow to that area. Anyway, getting back to the patient. At least the patient can turn the neck to the left-hand side now, as we can see. These type of cases are treated successfully by the chiropractor. We have to ascertain which muscle is involved, either the trapezius muscle, the SEM, or the levator scap, like in this case. We have to correlate anatomically and clinically with the cervical spine, the segmental restrictions as to what's happening from the joint, and correlate it with what's happening at the muscle. Now, we do know that C4 does have a nerve supply to the levator scap. Also, it attaches to the posterior tubercles, as we've seen in the anatomical image earlier. And we also know that C2 has an attachment and a nerve supply to that entire SCM and the trapezius muscle. We must not forget that cranial nerve 11, the spinal accessory nerve, supplies your SCM and your trapezius muscle, along with the motor branch from C3 and C4. And that's another reason why the manipulation or the spinal manipulation at these joints are so fundamental for improving the range of motion and getting these patients better in a shorter space of time. What I usually do in these patients is adjust the thoracic spine as well, which is about T4, T5, just to restore those biomechanics too. And often there's a reduction in pain after treatment 1 by 70%, and the symptoms are usually resolved by treatment 3. The patient's also advised to stop all NSAIDs unless the pain is extreme and severe. I always advise the patient to revise the pillow, their ergonomic setup, monitor their posture, and of course, to talk about stress with your patients, especially now with what's happening in this pandemic and in a post-COVID-19 world. The stress aspect is something you have to discuss with your patients as to what could be causing it, because it will just be a recurring type of episode with this neck pain. Also aid in stretching of the cervical spine range of motion with no external force, but active contraction, meaning that here I just tell the patients to turn the neck from side to side, ear to shoulder, and ear to shoulder. I don't allow any hands to be put and placed as an excessive force, because it just may be too overwhelming for the nervous system and the patients in this much of acute pain. No x-rays were requested in this case. And at a follow-up at 2 weeks, she reported no pain at all, no headaches, but just general stiffness of the muscles, but with full range of motion. And the myotome strength was actually restored with its shoulder abduction test. The possible causes for this here, and I find this to be a prominent feature in every single one of the cases, is there's always an underlying stress, a retrenchment on the cards, a divorce on the cards, something financial, something that happened in the weekend prior that actually had caused that mind to wander, and this muscle goes into spasm. The patient goes ahead and sleeps, and they wake up in the morning, and this neck's completely stiff. A recent change of bed or pillow can also start causing quite a bit of pain. Viral infection in the last 2 weeks, we haven't seen COVID-19 do this yet. Any exposure to a cold draft of wind, like an aircon or a fan, or from a car, a motor vehicle, that ventilation directly on the neck can also cause this. Any substance abuse, like ketamine, cocaine, can also cause these symptoms to come on quite immediately. So as a final discussion here, if the patient has any MRIs or cervical spine x-rays, actually any x-ray, examine it in detail. Do a thorough physical examination. Don't be afraid to consider chiropractic manipulation in these cases. Do not ignore any reversal of the cervical lordosis on x-ray. Always encourage cardio exercise at least 3 times a week for 30 minutes to the point where the heart rate's elevated. Like I said, in this case, no x-rays were requested. At our next talk, we will address another dreadful medical condition that I'm sure you guys see in practice, and so do I, called adhesive capsulitis, and I call it the shoulder that just won't move. We're going to be viewing its management plan along with its pathophysiology, and I look forward to having you guys present there too. Movement is everything. Thank you so much.
Are there any questions for Dr. Rama? Feel free to ask any questions to Dr. Rama or make some statements as well.
Good evening, everyone. Can you hear me? We are now open for Q&A. Dr. Rama will be assisting you with any questions that you have. We also will be having Rakhi Dulip from ENS Africa that will be giving us a little bit of info regarding the POPIA Act, and she'll also be available to answer any questions that you might have regarding what we're going to do in terms of the workshop. I will also be posing 2 questions while Rakhi is giving her talk. The questions relate to the presentation you've just heard, and as soon as the first 2 individuals answer correctly, we will ask you to send us some details, which is like your name, address, etc. I will type that into the chat box, and we will then courier you your lucky prize, which is a book.
I'm going to answer the why is back pain in the mornings more severe, thus making jumping out of bed difficult question. So the main reason why jumping out of the bed in the morning becomes difficult, and in about 80% of cases, those patients are also going to be getting pain when standing up from a seated position, getting out of a vehicle after driving for any period of time. So the main reason in those patients is now purely lower back pain, facet joints. And if you do a MRI on those patients, you're always going to be finding some hypertrophy of that facet joint. And that's the main reason. So you're stagnant, you're stationary, there's no movement, you're sleeping. You turn, you'll find movement, the patient sleeps again. Now you're going to wake up in the morning. So your dynamics or your biomechanics of your lumbar spine or your facet from getting out of bed in the morning, from being supine or recumbent to standing, you have to change your entire weight bearing capacity, and the facet takes all that load. So now you've got no movement, and all of a sudden you want to rotate that lumbar facet joint, and now you've got a force of gravity acting on it, and you're walking, you find that the facet starts to get inflamed. And as the walking progresses, what the patient usually would say is, by the time I hit the shower or the bath, the pain subsides. So that inflammation over that facet joint starts to subside, and the patient starts feeling better. But the main reason for waking up in the morning with pain or getting out of a seated position and you're getting pain is purely as a result of the lumbar facet joints. The lumbar facet joint is also as a result of the disc in that area becoming narrow. When the disc becomes narrow, your 2 facet joints come closer together. So I always give that analogy of a brick wall, and you've got the cement in between the bricks. So as the cement starts becoming more and more narrow, you start getting the bricks approximating. That is what causes that stiffness of pain when getting out of bed in the mornings. Yes, there is, sorry, I hope I answered that question successfully for you. Yes, there is room for some of the muscle relaxants. You can always, a lot of patients do tend to use the triple the 25 milligrams for this type of neck pain that I spoke of. Often, I find that they wake up in the morning feeling fairly groggy, and it does help them significantly, but the recurrence is still the same. The patients would usually find that after the course of the meds, they find that they actually start getting pain again. So the purpose of the presentation was more to emphasize on how we want to restore the range of motion that has been lost. And that's going to be the critical part, is once you can reduce the inflammation in the joint, once you can offset that entire irritation of the capsule in the facet, the patient starts feeling better. So the meds definitely does help in the acute patient. That's for sure. In your chronic patient with disc disease in the neck, they're also going to be benefiting from those meds. But I think that the crux of this talk was that in this particular patient and that series of patients, especially in the females, we are finding that they are much more prone to neck pain. And the meds gives them the relief that they need, but the recurrence still stays the same. So what we want to try and do is get that long-term management plan by getting the joint much more functional so the muscle can start to settle down and they got better integrity of that entire neck joints. And I can assure you one thing, If the patient presents more than twice or thrice with the same type of neck pain, send them for APN lateral X-ray, and you'll see that lateral X-ray looking where the curve has become lost. You'll see so much of muscle spasm there, and that's often where the diagnosis is to restore that curve. If there are any other questions, I'll be more than keen on addressing it now. Any comment on the use of inflatable collars? It acts as a traction or pull on the neck, especially for disc problems, and patients find relief. No, that is true. That is true. Now, so that's a completely different topic where we're looking at chronic disc degeneration. So C5, C6 discs, C6, C7 discs, where you find in these patients running out of space at an IVF. We're seeing those discs pushing directly into that spinal cord, osteophytosis seen. Definitely a place for the cervical traction, and you can go ahead and consider the inflatable collars. I know for a fact it does help patients. Once again, it's a temporary relief, but it does help patients that are still on the borderline of whether you should send them for any facet blocks or rhizotomies or doing any cervical disc surgery. The traction technique would help. But like I said, the indication for that is going to be multi-level disc narrowing, multi-level discogenic disease in the cervical spine. Actually, I think that's going to be the best indication for those patients that will require the traction or the pull on the inflatable collars. How best to prevent neck pain from developing? Look, there's many factors that we need to consider. The first is going to be, like I said, usage of technology can always play a massive role. Genetic predisposition is another. Previous trauma like rugby injuries, soccer injuries, motor vehicle accidents, weight-bearing exercises that are overwhelming for that spine. Those are factors that makes neck pain worse. So I would always suggest try and keep good posture. Always try and do adequate exercise. You don't have to be the biggest guy at the gym, but good toning exercises and a good cardiovascular workout. So anything that requires you to be a bit more upright. If your daily activity requires you to be behind a PC, or if you're desk bound, try and do your exercise program outside. So avoid doing stationary cycling in those patients. Rather try and do a bit of a brisk walk outdoors, that type of thing. So it's a multi-factorial pathology, and many things can actually help in getting it better. If there are any other questions, I'll be more than keen on taking them.
Hi, good evening, everyone. Thanks, Dr. Rama. I caught the tail end of that session. And I must say, I think I'm guilty of all of these things that you said we shouldn't be doing. So I'm a lawyer and I sit behind the screen all the time. So hopefully all the doctors on the call today will be able to help me out better going forward. Okay, thanks. I don't think there are any other questions, but I'll leave it for other people to add, and maybe I'll just chat a bit about the data privacy law, and then if there's any others, we can pick them up if that's okay. Thanks. Okay, so good evening, everybody. Thank you for joining today's session. Thank you to the ChipDev Training Academy for having me this evening. I thought it would be great if you can just get a sense of one of our upcoming workshops. We are going to be doing 4 evening sessions, 2 hours each in March, dealing with the Protection of Personal Information Act. And for some reason, I seem to have almost forgotten it. So it's called POPI or Papaya. That's the latest data privacy law that's going to be affecting everybody, regardless of which industry or sector you operate in. This data privacy law deals with the processing of personal information, and it's so broad as to what that means. And it doesn't affect, just one sector. Like I say, it affects everybody, and none more so than, all of you in the medical professional field. So personal information is any information that can personally identify a person. I know that sounds like a very legal term, but essentially, if you're dealing with people's names, their contact information, their health information, anything relating to a person, that is personal information. And then if you process it, so whether you use it, you collect it, you store it, all of that is processing. And what POPI does is it brings in some processing conditions. It brings in some criteria around which you now need to be processing personal information lawfully. So in addition to all of the other laws that apply to you in terms of the National Health Act and all the guidelines around how you deal with health information and data from your patients and the confidentiality that you have between you and your patients, you now also need to be complying with this data privacy law. And in the coming workshops that we have, we will be breaking down for you what that means. So we go into all of the details around what the law means and how to be compliant with it. So I hope that gives you a little bit of an insight as to, why it's important. Perhaps it's also good to know that, if you are not compliant with POPI, most people want to know what happens next. So if you don't comply with POPI, people can lay complaints against you, against to the information regulator. They're the public body that's going to be tasked with dealing with people's compliance with POPI. And if you're found guilty of not complying, you will actually be fined, or you can actually face imprisonment depending on, the offense that you've committed. And the fines that organizations, may be liable for can be anything up to 10 million rand per, data breach or breach of an offense or breach of any of the obligations in terms of the law. So the impact on your organization for not complying with the law is very high. So it's a very risky business dealing with data, but we are in the information age and everything we do is around data. And, what this law does, it brings in that element to make sure that patients' information, all data subjects' personal information are, sufficiently protected and kept confidential. That's the essence of the law and why it becomes so important for us. It's good to know that the law actually will be in full force and effect from 1 July of this year. So we just have a few more months left in order to become compliant. The law was signed into law by the president on last year from the 1st of July. And we're currently in that grace period. And because there is that grace period, it becomes really difficult for any regulatory body like the information regulator to be lenient. They're going to feel that everybody has had more than enough time to comply with the law. So come 1 July this year, they're going to take their job very seriously and make sure that people are complying with this data privacy law. So I hope to see you in the workshop next month, and look out for any other sessions. If you can't make this one, we will be doing a few of them where we can break down for you specifically, POPI and the impact it has in your organization and how to be compliant. Thanks. If you have any specific questions about the workshop, I'd also be happy to answer them.
Good evening, everyone. We've now had Raki giving us a bit of an overview about POPIA. Please feel free to ask us or ask us to send you any information you require regarding this workshop. Thank you, Raki, for enlightening us on that. We do have a few of you that have sent us answers. Please, I'm going to send you contact details, so you can either SMS or email us with your details. I would require your surname, your address, and contact details so that we can send you the book price. Secondly, just a wonderful evening to each of you. And then a big thank you to Sunil for giving us that informative talk. And Meena, I'm not sure if you want to say anything else, but you're quite welcome to come on while I do a bit of typing in my chat box.
Hey, Jessica, have you heard of this poppy thing that everybody's going on about? I mean, some people say poppy, some people say papaya. It sounds like a fruit to me.
Hey, Raki. Well, no, it's certainly not a fruit. Papaya is the Protection of Personal Information Act, and it was enacted to give impetus to our right to privacy, which is enshrined in the Constitution.
Ah, that seems to make a lot more sense than it being just a fruit. But I mean, why would that ever be relevant to me? I mean, as a medical professional, why would anyone even be interested in something like this?
Well, papaya applies to any organization that processes personal information, or rather uses personal information. And as a health professional who may have a practice of your own, who may be running a practice, you will necessarily come into contact with a range of different types of personal information. And while you are subject to the National Health Act, there are additional obligations in papaya which you must ensure you comply with whenever using personal information.
Okay, so there is this workshop that's coming up. Can you tell me why should I attend that, and what are we even going to do there?
Well, the workshop is a really good idea because you need to ensure that you are compliant with papaya by the 1st of July this year in 2021. And the workshop will help you understand the critical aspects of papaya and will also be your first step in being compliant.
Okay, that sounds great. So the million-dollar question, what happens if I don't comply? What if I choose that poppy is not important enough?
Well, you might come to regret it. There are administrative fines which can range up to 10 million rand. There are also claims that can be made against you by data subjects, that's the people to whom personal information relates, from the information regulator as well. And there's also the possibility of criminal sanctions. So not complying with poppy isn't really an option.
Sounds like it. I guess I'll be there. Thank you.
Thank you.